Um, oh, okay.
Sorry, I forgot to push record.
Well, it's probably a good thing that no one actually will record what I just said. Anyway, they're here with us. We also have Research Development Associates, RDA, with Julia, who will actually be kind of carrying through with our discussion. And then we also really fortunate to have some folks from Partnership Healthplan, and because they will amazingly be playing a great role in this process, which we're super excited about, and you'll get to hear about today. And so I'm going to turn the time over to Julia right now.
Great. So our agenda today, Scott, thank you so much for the overview and helping kind of seat us in the context of why we're here today and talking about the Pathways Hub, how we're going to integrate coordinated entry. And additionally, we're going to talk about where CalAIM comes in. I'm sure a lot of people have heard whisperings of CalAIM, or maybe you've had some experience with whole person care, but we're going to get to an understanding of how that fits in and aligns with this model we're thinking about with the Pathways Hub. And there's really exciting alignment, and it could impact your agency or your organization you're working with, and give some sustainable dollars to this work, and really help us integrate it and create some long-term solutions that provide more integrated services for the people who need it the most. So after Marilyn from Adventist Health talks more about the Pathways Hub, let's really get an understanding here. It's a new way of looking at things. If you have questions as we go, please ask. It takes a few times to really, absorb it. So we want to give you that opportunity to absorb it and ask questions. So please do. We want to make sure you understand the model. And we have some follow-up materials for you afterwards. And then we have partnership here. Danielle is gonna really dive in with us about CalAIM and how, enhanced care management and community supports tie in. And then we'll do some QA and give you an opportunity to give feedback. This space is for stakeholders to understand the work that is going on here and to take part. So there's a call to action of finding your niche in this work. We can go to the next slide, and I am going to pass it over to Marilyn from Adventist Health.
Thank you. And we can go to the next slide, please. So I'm sorry, I just was diagnosed with COVID again. And so I'm not doing great, but I'm doing my best to be here and to present the information.
Please tap me at any point. I'm so sorry to hear that.
That's okay. It's not what I was expecting, and certainly not what I was hoping for. So the Pathways Hub, Lake County has been working on something like this for several years, and providing as a way to provide closed loop referrals to Lake County residents, not only those experiencing homelessness, but those experiencing behavioral health needs. And lots of agencies are doing different pieces of this. And we haven't had a coordinated way to make referrals and to follow up on those referrals, and also to collect any data. And so we started working with Pathways Hub last year. And Scott, through Lake County Behavioral Health, was able to get a grant that allowed us to hire CCS and help us implement the Pathways Hub. What we're looking at right now is to help the stakeholders understand the importance of this and actually move forward with training. And we are planning our first training in September. And I'm not sure, can you go to the next slide? I'm not sure what the next slide is. Oh, so let me talk about coordinated entry, and then we'll talk about the next steps. Coordinated entry is a requirement through HUD for any county entity to receive funding for low-income housing. And so the coordinated entry system, it requires anyone working with someone who's experiencing homelessness to put that money, Department of Healthcare Services, yes, instead of HUD, for this grant. The coordinated entry system requires that basic information about this person is put into the system, and there's a assessment that's done to determine their risk and their vulnerability, and then the CES actually prioritizes the individuals based on their vulnerability scores. And so then those people who are working with housing individuals are required to start with the people who are at the top of the list. And so someone who has young children is more at risk than an adult single person. And an adult single person who has high medical need is more at risk than someone who has no medical need or very limited medical need. So that's kind of how the priority system works. We're working at how we're going to integrate all of this into one process. So anybody in Lake County who is needs services will be entered into the Pathways Hub. In addition, anybody who's experiencing homelessness will be entered into CES. And so we're trying to figure out how the systems can talk to each other and how we would be able to reduce any kind of replication of information. Okay, so let's go to the next slide. The importance of the community hub is being able to provide information about the client or patient that we're working with and to the client or patient that we're working with. And within each, or for each individual who is being entered into the system, there will be one agency and one person who is designated as their primary caregiver, our primary care provider, care coordinator. And that person is the person who will generate referrals and who will follow up on those referrals. Anybody else who is being referred to will check back through the primary care manager to determine what are the next steps, who's doing what, and that's how the coordination of care will take place. Within the system, the data we'll be able to pull will allow us to see where the bottlenecks are and how to resolve those, and then we can make plans to resolve those bottlenecks. So let's say a lot of patients our clients are being referred to a particular agency, and we're finding that that agency is not picking the referrals up or not acting on those referrals. And then using a real scenario, come to find out that person has COVID and is out. And so then, you know, working with the agency to designate somebody else then to pick up those referrals while that person is out of the office or whatever. And we'll be able to run real-time data so that we can then act on that. And it's also a process improvement part of the whole system, so that we're not saying, oh, well, so it's working great, so no, and we're doing everything right. It will allow us to see where the hot spots are or the bottlenecks or whatever, and focus in on those things so that we can continue to improve the whole process. The client will also be able to look at the system, and they will have their own little portal, so they can look in and see what referrals have been made for them, when there are any upcoming appointments, if something has been changed or someone is sending them information or a form to fill out or whatever, they will be able to see that in real time too. And I believe, if I'm remembering this, what Michael said from CCS, that they'll be able to receive like emails that will update them on where things are at. And one of the emphases then for the direct care managers will be to help people on their smartphones set, if they do not have an email, helping them to set up an email so that they can then get those reports and messages. Okay, next slide. And this is the timeline that we had established. This is through the end of the grant. And we have our first training set up for September. We don't have a firm date yet because we're looking for the location, but it will be 2.5 days, and it will be for, the training will be for anybody, any direct care manager who is on the ground already working with clients and their direct supervisor. And we can accommodate probably about 20 people in the first training. We'll be doing additional trainings as well. And then we will also be holding a innovation summit this fall, probably early November. And we're currently looking for locations for that. And we will be planning for the hub, our Pathways Hub, to be one of the focuses of that Innovation Summit, explaining how it works, actually showing some examples, and then having some of the frontline workers talking about their experience using it. And if we, by that time, if we've had some clients that have been working through this with that system, having them share what their first person experiences are. I also want to introduce Heather Frawley. Heather is our new project manager that we have hired for the Pathways Hub. And she is on through the duration of the grant. And we're very pleased to have her with us. Her background is, she's done a lot of data analyzation and that sort of thing, but she's also has a master's in public health administration. And I'll pass it back to you, Julia.
Okay, thanks so much. Can you go to the next? I'm going to cruise through some of these next slides, Patty. So this one shows the key current partners in kind of the core group, trying to get this Pathways Hub concept and model up and running. You could be a care coordination agency here. That's the first one. So those are the people who are doing the lead care management, are supporting clients in this very hands-on way, navigating multiple systems of care. Adventist Health is, of course, leading the way. Thanks, Marilyn, for all the exposition on what's going on. CCS, they run the tech. It's their beautiful model, and they're going to be doing the training on these models. And they have HealthBridge, a community health record, essentially, which is where all the data is stored. And then this great closed loop referral system. So that's all their technology. Lake County Behavioral Health has bravely taken the lead on this concept long ago and is making sure that stakeholders are apprised and brought in and really coalescing the people around this vision. And then us at RDA, we are doing some back-end stuff, making sure stakeholders are aware of what's going on and plugged in, and then also doing the reporting to the funder. Next slide. This has been mentioned already, but just to reiterate, the initial focus of this model is going to be on people in the experience of homelessness, and then also people with behavioral health, both mental health and substance use disorders. Next. We talked about this, but this is kind of the overarching vision Marilyn was speaking to, is this kind of gives some metrics around how many care coordinators we're hoping for. And care coordinators can mean a lot of things. It's direct service staff. It's the person really like taking the lead. So it could be a community health worker. It can be a case manager. It can look like a lot of different things. So just some level setting with terminology there. And then we can go to the next slide. I think this is super critical. So for direct service staff who are going to play this role as a care coordinator, there are some core competencies that are listed here of kind of what's expected from that work and a scope of work. So We really want them to use evidence-based best practices like motivational interviewing, trauma-informed care, understand the community and what resources are really available for individuals in these experiences, to do service coordination, capacity building, advocacy, teaching and education. And then the scope of work is actually doing that care coordination and connecting people to a care team and making sure this person is tended to, systems navigation, coaching and social support, coordinating with involved systems of care. So they might be justice involved. They might be working with the behavioral health department on specialty mental health. You know, we all know, like, being in this world that people are having to navigate a lot of complicated systems. And so if you have someone who's your navigator, who's your core person you go to, it makes that a lot easier. To assist with referrals, right? Closed loop referrals is a dream, right? When you're in direct service, like, there's so many times where you don't know where a referral landed and there's no way to check in. There's no system for accountability around it. So this is really a boon. This is like the gold standard of what every community is seeking right now. And we have the tool in our hands and it's about to be implemented. So it's super exciting. It's the other aspects are contributing to a team for care planning for the individual, assisting with transitions between providers and phases of care. So, you know, sometimes the client needs a higher level of care and you might need to move them up in the system. And then ideally, fingers crossed, someone needs a lower level of care and we're able to step them down. And that's the goal. Then there's connecting patients to community resources, facilitating patients' attendance at medical and other appointments. We know how hard it is for people experiencing homelessness to remember appointments and to have the ability to show up due to transportation challenges. And just, there's a lot of barriers to entry. A lot of people are not treated well in the medical system when you're experiencing homelessness. You're not able to tend to your hygiene, or maybe you're having trouble with your mental health and you're already feeling very paranoid. There can be so many barriers. So if we can build strong relationships with an individual, we know that breaks down those barriers. And then finally, to conduct case findings, recruitments, enrollments. So this is the overall vision of what the care coordinators are really doing with individuals. We can go to the next slide, Patty, thanks. So where does your organization fit in? Are you already providing care coordination? Are you an org that's doing similar services that wants to be plugged in the Pathways Hub? You actually don't have to be a care coordinator specifically to be in the Pathways Hub. There's a lot of ways in. It's a community effort in so many senses. But this is more of a rhetorical question. You don't have to answer right now, but we encourage you to follow up and ask questions. You can go to the next slide. I think it's a question slide. Yeah. So I would love to know from you guys as what are your hopes and expectations on how the system will be used to enhance services in our community? And what questions do you have about the Pathways Hub? I'm not going to assume we just did a really good job explaining it. It took me like 5 times reading the materials to totally get it. So.
This is Kim, and before I get kicked off again, I just wanted to ask, in other counties or areas, what is the role of public health with something like this?
Kim, that's a great question. It super varies from county to county. And I think, Danielle, you probably have a really healthy look into this, being a managed care plan with CalAIM, because y'all are digging into this work in so many counties. What role have you seen public health play in these efforts to coordinate care?
That's a great question. Good morning, everyone. You know, it depends on the county, I would say. We're actively engaging our public health offices in our 14 counties that we service to potentially become ECM providers or enhanced care management providers and potentially community sports providers. But I think there is an active role. I think it just depends on where you see yourself fitting in. I think that you could be a potential provider. You could also, if you handle referrals, you could play a role there. I think it just depends on kind of the scope of where you're headed with your organization.
Yeah, and I think I've seen public health take kind of a more overarching role. There's a piece of CalAIM called population health, and that seemed to kind of fall more into the hands of public health departments. But it kind of just depends, every county, their departments are oriented a little differently. And I've seen it have to do more with if you are providing direct service to the priority populations, which Danielle will lean into talking more about. For the Pathways Hub, our priority populations are people experiencing homelessness and people with behavioral health needs. So I want to just address some of the comments in the chat. One, Kim, thank you so much for that comment. I think that can be an evolving conversation, and really encourage you to chat with partnership and work on that evolution of how Lake County is pursuing CalAIM initiative. And sorry, guys, we haven't covered CalAIM initiatives yet. So sorry if I'm speaking beyond what we've shared thus far. We will dig in, I promise. I want to address in the chat, Terry said that for their hope is that people we work with don't fall through the cracks. Do you want to express more about that, Carrie? Like the goal of the system is really a coordinated effort that is data driven, and hopefully will lead to less people falling through the cracks because it is more intentional. It's has more infrastructure to monitor something like that. But can you share maybe what you're thinking? Maybe you serve a population that isn't the priority population here.
Well, no, I work over at behavioral health. I supervise our peer support centers, and one thing that I've seen with our unhoused population is that people tend to kind of drift away. And then, before you know it, there's 3 agencies in the community that are all providing the same service to this person. Or on the other side, the person is not receiving any of the services, because they've never followed through. And how do I know that without being able to look, in the in the system and go, oh, okay, they never followed through. Let me drive them over there, find out what the barriers are. And so that's, I guess, my hope. I think I'm understanding this correctly. So
we didn't pay Carrie to say that, by the way, everyone, but what a perfect setup for why this system is so valuable. We know we're out there duplicating efforts and we have no idea. I know I worked in homelessness for 8 years, and I know there were so many times where I'd be speaking with someone in the experience and we'd be working on something, and then they would suddenly mention oh, my other case manager, we did something similar. And I'm like, you have another case manager, and I would ask those questions, but not everyone's going to share that, or maybe they don't view that other person as a case manager because their title is different, or without a system that coordinates care and intentional mechanisms, we're undoubtedly duplicating care. And then the closed loop referral is that other mechanism to say, did my referral actually land? Because right now, so much of it's, and I can't speak for your county because I've not provided direct service in Lake County, but you think a referral's gone through, but maybe someone like Marilyn's example was out because they had COVID and they were the person who's supposed to respond. And there's no checks and balances for accountability of well, did that land or did it just fall on one relationship with one person? Which is how a system should be built. It should be very relational, but it should also have mechanisms where we can check in on and not duplicate efforts. So thank you, Terry. Thank you so much. That was a great comment. And we really hope this system meets those needs, and it will take some time. So I am going to say be patient, because implementing a new system and getting adoption really takes time. So it's not going to be perfect off the bat, but it is really made to address those issues.
And Julia, if I could jump in here, this is Marilyn. I was going to add that the role of the we have a project manager, we're going to have a project coordinator as well. Their role through the duration of the grant will be to help us to problem solve and to see you know, where do we still have questions, where are things not working smoothly, and really help us work through those details. The trainings that we're planning also will help the direct care managers determine who should be the lead for this particular client or patient, and how is that determined. Some of it will be by our specialty groups that we work with, like Redwood Community Services works in the county with youth and young adults. That's one of their specialty areas. They have others as well, but if we're working with someone who's underage or aging out of the foster care system or whatever, we're going to refer them to Redwood Community Services to be the lead care managers, because they have a lot more information and a lot more resources available to them than we do for that that population. So hopefully that will also help us to determine who do we go back to. Whoever's the lead person, lead care manager, will be the person we'll go back to help us navigate with a particular client, so that we're not replicating and we're all helping to further the needs of the individual.
Yeah, Marilyn, thank you so much for that context, because there are going to be people holding these really specific roles, tending to the system and iterating on it, and adding your feedback in and helping problem solve and troubleshoot. And yeah, thanks for sharing that additional context, Marilyn. I want to address Israel. I hope I'm saying your name correctly. In the chat, you said that you hope that we're able to meet the needs of the clients where they are in their executive functioning, various systems and people putting their helping hands in. You also expect that this will be, in turn, provided more appropriate support for the client. Anything else you want to add to that? I think that's a great vision.
Can you hear me? So basically what I'm getting at, and I want to peeky tail on what everyone else is saying, but, with having a collaborative and a collective effort, working together, it'll be an easier method to identify what's going on. We all come with different levels of expertise and experience. So that's really how, in my opinion, where we're really going to get to what's going on with our clients. And that's basically what I'm getting at.
Yeah, that higher coordination of care will give more appropriate services to the needs the client is having, right?
Yes.
Awesome. And you're aren't you doing care coordination? Is that what you said?
Yes, I am with Redwood Community Services.
Awesome. So here's someone who's already doing this work. So Israel, it's really cool to hear from you, and maybe we can dig in more sometime, since you have on the ground experience with this, and a lot of
love to.
Yeah, a lot of it's been hypothetical for us in some ways, right? So thank you for being here and sharing your insights.
You're welcome, and thank you.
And yeah, Redwood Community Services are total trailblazers here, and we've super appreciated your input and involvement, and jumping in to be some of the first CalAIM enhanced care management providers in multiple counties, right? Yeah. So you guys are super cool, and kudos to you. Okay, we can go to the next slide, Patty. Okay, so we are talking about this concept of the Pathways Hub, and then we're also kind of integrating conversations about CalAIM, and there's a lot there to unpack. We don't need to get into all of the intricacies of it, but I just want to share these overarching matches in vision that align the Pathways Hub with some of the main CalAIM innovations. So the goal of having care coordination and closed loop referrals and the approach to using the Pathways Hub model are aligned with the goals and approaches of CalAIM, specifically enhanced care management, which is the idea of having this care coordinator, and it is pretty much exactly what we've been talking about around care coordination. There's some other specific intricacies about the service provision with that and what's required. And I would say the administrative side of it's pretty different. And then providing enhanced care management is one way to get sustainable funding to be a care coordinating agency with the Pathways Hub. So we're not saying it's the only way to be a care coordinator, but it's one pathway we see as the most financially sustainable, because it is so aligned, and it is, you know, this new program, and there's a lot of effort and funding and infrastructure that's being built into it. And then it happens to align with this vision that is already underway, and funded by the precursor to CalAIM, which was Whole Person Care, which was this awesome pilot program that helped us understand how to best serve people in these vulnerable populations. And it got pushed forward into this ongoing work that is CalAIM. So the key tenet of ECM that ties this in, that I want to say around funding, is that it makes it Medi-Cal billable. So that is, for understanding the funding piece, that's super important to know. Okay, that being said, we can go to the next slide. I am going to introduce Danielle from Partnership Healthplan to tell us more about CalAIM and kind of explain that work. And you can go to the next slide, Patty.
Hi, everyone. Good morning. Thank you so much for having me here. My name is Danielle Biasotti, and I am with Partnership Healthplan. I am the Enhanced Care Management Manager of Operations in our Care Coordination Department here at Partnership. So yet another care coordination theme here for you. And I will be presenting to you some big changes to Medi-Cal. And the biggest one is California Advancing and Innovating Medi-Cal, also known as CalAIM, and the new Enhanced Care Management benefit, as well as the community support services. Next slide, please. So to give a little background about what CalAIM is, it's a giant initiative. It's a 5-year initiative from the Department of Healthcare Services, and it's to improve the quality of life for members or enrollees and health outcomes. And it's an initiative that encompasses a variety of changes to better integrate care and improve outcomes. The focus is to help folks with complex needs that are facing difficult life and health circumstances. And so under this initiative, there's several different proposals, which would be this enhanced care management benefit, community support services. I did hear earlier the population health management. There's an initiative under there. So there's a lot of things coming down over the next 5 years. But today I'm here to just introduce enhanced care management and community supports. Next slide, please. So enhanced care management, this is a new benefit. I have to highlight benefit versus services, so it makes sense and you can see kind of the difference. It's designed to address both medical and social needs, and it's a comprehensive case management, and it addresses their needs through improving care coordination, integrating of services, facilitating community resources, improving health outcomes, and trying to decrease inappropriate utilization and duplication of services. So it's a benefit that's high touch, it's person-centered, it's provided primarily in-person interaction where the member lives, seeks care, and prefers access to services. And this benefit will be provided by an ECM or enhanced care management provider and assigned a lead care manager. And this lead care manager will coordinate that care and the services among physical, behavioral, dental, developmental, and social services, making it easier for the member to get the right care at the right time and tackle some of the challenges they're having and overcoming some of the barriers that they have. So some of the key components are, again, face-to-face. This can be with the member on the streets, in a doctor's office, in a shelter, at home, at a coffee shop. It's really based on where you can find the member and where the member prefers to meet up with their lead care manager. And so this member has to agree to this ECM benefit and really can opt out at any time. That's key. And then there's 7 populations of focus that are specific to this benefit, and we'll go over that in the next slide. Next slide, please. Oh. Okay. My slides are different than yours, but I'll just move forward. So here you will see the enhanced care management core services requirements. And this is really what is required of an ECM provider. There's that face-to-face outreach and engagement, where it's community-based focus. There's a lead care manager assigned. There's risk screening and assessment that needs to be done, social determinants of health planning, developing that care plan with goals and barriers and sets and target dates, cultural competent communication. And then the biggest piece of it all is that coordination of care, access, advocacy, really supporting that member with the various needs that they may have and tackling some of the challenges they're having. Next slide, please. All right, here it is. So the population of focus, there are 7 you will see here. And so backing up, in order to be eligible for the ECM benefit, the patient must fall into one or more of the populations of focus. So the benefit's designed to help those with the highest level of complex healthcare need, as well as having some social factors influencing their health. So the first 3 here on the screen, they have gone live, and I'm going to go over the timeline in the next slide in a minute. Live in all 14 of partnerships counties. There is specific DHCS criteria. We did provide the link to it because it gets into it in more depth than what's portrayed here. We kind of just summarized for you on the population. So if you're interested in knowing more, please check out that link. Again, the 3 populations have already gone live in all 14 of our counties. And then you'll see that the next one down is transitioning from incarceration. That was delayed. We're waiting on a new target date. Obviously, there's importance there for that population. And then the next 2 will go live in January. And then the other focus is children, which will be for July. So we'll go over to the next slide and you'll see the timeline. I kind of jumped the gun. Yes, so phase 1 and 2 have already gone live, again, for those 3 populations of focus: high utilizers, homelessness, and serious mental illness, substance use disorder. And so now we're preparing for, we're still going through phase 1 and phase 2 for the program wise and the benefit, but we're also preparing for phase 3 and for phase 4, and also the incarcerated members coming back into the community when that population goes live as well. So for January, you'll see that the next round of population of focus is nursing facility residents transitioning to the community. Of course, they again, I'll refer to the DHCS specific criteria, but the individual will want to come back to the community also, so we want their buy-in. And then there's also folks at risk for institutionalization. Again, incarcerated members coming back to the community has been delayed. And then the phase 4 is children and youth with complex and physical, behavioral, and or developmental health needs. And we're also still waiting for additional guidance on what that looks like and how that intersects with other programs. But we are trying to prepare the best we can for that population to go live. Next slide, please. Okay, so before we go into the community support services, I think I might want to just pause and see if there's any questions while they're fresh in the mind. I'm trying to look in the chat. Sorry, 1 second. Okay. Oh, I think one just came in. When you say at risk for institutionalization, how is that measured? So the exact criteria that DHCS gives us is adults 18 or older without services or supports that would require care for 90 consecutive days or more in an inpatient nursing facility. So that is the criteria that DHCS gives us.
Does that apply to drug offenses?
You know, the incarcerated member description and criteria, they did give us something, DHS did give us something, but I would hold off on reciting that because I feel like it may change because of the delay. So I would say no, that would be different and unique to the incarcerated population.
Do we have a timeline on the delay with enhanced care management for justice involved individuals?
We do not. I said that they would release something 90 days before implementation. So we may have 3 months notice.
Oh my goodness.
there are work groups happening in the back end for that readiness, and also working with the whole person care counties that did work with corrections and justice folks across the whole state to find out what worked, what didn't. And so I think that's all being evaluated, but we do not have a target date. I mean, we could maybe assume July of next year, so in a year, but I'm not 100% sure on that. Okay, we'll go ahead and move over to the community supports, or known as CS, and these are the services. So I spoke about the benefit, and now we're going to switch gears to the services. So community supports, you may have heard previously in lieu of services, or ILOS or ELOs. In December, DHCS switched the terminology, so it went from in lieu of services to community supports. So I just wanted to clarify that others had been confused. But this is a service that is, these are services that are non-traditional for Medi-Cal plans or partnership to cover. And so now switching gears with CalAIM, these are services that potentially can be covered in lieu of a traditional Medi-Cal service. So again, this is separate from the ECM benefit. It does align nicely with it, but members do not have to have the ECM benefit in order to get community supports. They are separate. And so this is really a way for partnership and managed care plans to address social determinants of health in a cost-effective way, and replacing maybe some hospital stays with having them stay in like a recuperative care center of some sort. So there's 14 possible services. You'll see here on the slide that DHCS has presented to health plans, and partnership is covering 6 out of those 14 currently in our 14 counties, and we're looking to expand for January. Health plans have opportunity to add services every 6 months. So we're looking at that now, but currently I'm going to list them off for you. I'm sorry we didn't highlight them. I do have a flyer I could share after if that will be helpful, but the housing transition navigation services, that is one of the possible services partnership offers. This is like searching for housing, conducting housing assessment. There's also housing deposits. That's another one. Security, like such as security deposit to obtain an apartment lease. Then there's also housing tenancy and sustaining services. So this is education and training on like the roles and rights and responsibilities of a tenant and a landlord. Then there's short-term post-hospitalization housing. The goal of this setting is to provide individuals with ongoing support necessary for recuperation and recovery. And then there's recuperative care, medical respite. This allows individuals to continue recovery post-hospital discharge or treatment. And then maybe getting some access to transportation, food, and housing at the same time. And then the 6th service that we offer is the medically tailored meals. An example of that would be meals delivered immediately to a person's home after they've discharged from the hospital. That way they're reducing their vulnerability. Maybe they have a medical need and need food and if they don't, they could potentially be readmitted. So there is strict criteria from DHCS on the services as well. And there's restrictions and limits, but we wanted to just kind of give you the skinny on the 14 services and then the 6 that partnership are currently offering. Any questions on that? I will do my best to answer. And if not, I will take it back. Sometimes the questions are very in-depth, so let me know what you have. And thank you, Julia, for providing the links.
So does DHCS, Department of Healthcare Services, is the state entity, just so folks, have that information. Do they require managed care plans like partnership to provide all 14 services by a certain date?
No, not to my knowledge. The plans are able to evaluate their network, their current network, and services are offered and their members need, and then make that decision. So it's not required. Those are the 14 possibilities.
And then I wanted to say something that what I'm seeing in a lot of communities is providers who already provide these services are just switching over the funding stream of how they're providing the services. And some of it's now covered, you know, as a service through Medi-Cal. Through their partnership, right? They're contracted with the managed care plan to provide those services specifically to eligible persons. And Danielle already said this, but I want to reiterate it because I think it's a little confusing. You don't need to be getting enhanced care management, one of those 7 populations, to necessarily be eligible. There is eligibility criteria for each of these community supports, but it is not the same as the enhanced care management eligibility criteria. So that was something that wasn't clearly explained to me for a while. And so just wanting to reiterate that.
And a lot of these services partnership tried to pay for previously, but now there's an actual way to do it. So we were trying to be innovative from the get-go. And so it's great to see that there's a billable way and yes, pay providers for the services under the community support services. Okay, next slide, please. So here we wanted to provide a list of our providers that are currently ECM and community support servicing Lake County. You'll see that there's contracted and then in process, because our goal really is to expand and have a robust network across all 14 counties and contract as many folks as we can. It's not a competition. It's really to work together to better our communities, help folks get the services and care that they need. So this is just a snapshot of our provider network currently. And I can speak to our partnerships provider directory does have a filter for community supports and enhanced care management. So if you're on the website and want to look for a specific area, or a member does, we have that functionality built into our provider directory now. And this is ever changing. So if you send in a questionnaire and you're on the call and you already know about all this and you're not seeing your name, that could be why. This is, it's constantly evolving, just in case folks don't see their names there. Okay, next slide, please. All right, so maybe you haven't submitted a questionnaire or you're curious, you want more information. This is really just an introduction. We can definitely set up meetings to talk more. We provided our email here on the slide. If you're interested in becoming an enhanced care management and or community supports provider, we do have providers that are both. We have a questionnaire we'll have you fill out, one for each. And then what we'll do is we'll review it and most likely reach out to you to chat more so you can get to know us. We can get to know better for the questionnaire. Otherwise, if you've got questions before submitting, you can reach out to us via email. You will have certain folks respond to you. We've got dedicated teams to work on community supports and enhanced care management. And so we'll be available to speak with you, email, set up a call, whatever you need. And the questionnaire really is based on your expertise with the population of focus or with providing those services. It goes over a number of things such as, how many members can you service? What are the services? What other organizations in the community have you worked with? That way we know that you're actively involved in collaborating with each other. And it's not a pass or fail, it's just getting to know you really. And then working together on making sure that the requirements are met, because we do have specific DHCS requirements to have met. But we will go all over that with you as well when we chat or email or call. Next slide, please. And then a couple of resources for you. Again, reiterate that Colleen email box, reach out to us to start initial conversation or questions. We also have a slew of policies we've developed for enhanced and community support. There's credentialing policy too. One requirement for ECM to be enrolled in Medi-Cal, and if there's not a pathway, we have specific credentialing processes, and so we provided that link. Our partnership county webpage has so much information on it: webinars, recordings, resources, tools, even external training on case management. You name it, it's probably there. I recommend that you check that link out. And then we also provide the DHCS web link in case you want to dive real deep into more of the state requirements.
All right. Well, Danielle, thank you so much for representing partnership and explaining these concepts in such a comprehensible way. Really appreciate your presence here. And please reach out, you guys, if you are not yet providing these services or have additional questions. Partnership is just such a wonderful, warm resource for this, and have so many great materials to help you dig into these concepts and join into this effort to provide better services to our folks who need it most. And it really, the work they're doing and have already been doing, as Danielle mentioned, is helping promote a future with more equitable care for folks and provide additional resources that we have needed for a long time. This effort around care coordination has been going on at least since the 70s. People have been wanting a way to coordinate care and use community health workers, use peers, use social workers to be, we have primary care providers in the health world, but what about for behavioral health? What about for homelessness? And these systems have been what people say is very siloed in their own space, and they need to be better linked. And this is an effort to really mesh them together and make that not the job of the vulnerable person to figure that out, who has all the barriers going on in their life and, a lot of lack of access for many reasons, where we can come in as providers and do those linkages and do the communication and make sure we're not duplicating and make sure referrals are in a closed loop. And so this is really the funding and widespread policy and political will to do big things. So Danielle, thank you so much. We can head to the next slide, Patty. And the next slide. Okay, so this is the call to action. Marilyn, do you want to take this? I'm happy to do it if you'd like as well.
Go ahead, thank you.
Okay, I want you to rest your COVID voice. I just had COVID too, so I really relate to the struggle there. So we have a couple calls to action. We learned a lot. This is a lot of information. A big one is there is a direct service staff training for the Pathways Hub coming up in September. We have Heather here. She's going to be leading the charge. I will, hey Heather. We will drop her contact. Heather, do you mind just dropping your email in the chat? That'd be great. Okay, so you can contact Heather for a bunch of these awesome things. So if you're interested in getting trained on the Pathways Hub, how coordinated entry is going to fit in, just, there's a lot to learn about how the system works. Please just contact Heather. We will do a follow-up email and make sure her info is in there. And also so you can pass on some of this knowledge if we have colleagues who weren't here or partners in the community who weren't here. We want to make sure this info gets spread around and that the community feels welcome to this. This is meant as a community effort, right? This system belongs to all of us. There are leaders making sure it gets carried out and happens, but it's meant to be a collaborative effort. So want to make that invitation clear. And then that coordinated entry training is part of the Pathways Hub training. And then we're going to do the Innovation Summit is going to be mostly focused on the Pathways Hub this year. It's going to be in November. Heather is also the point of contact for that. Heather, did you want to say anything else about the Innovation Summit or?
I'm working with leaders who previously have put on the Innovation Summit. And so I haven't met with her yet. So I'll have more details to come and I'll put out a information on that.
Awesome. Thanks so much, Heather. We'll look forward to getting that. Okay. And then applying to CalAIM initiatives like enhanced care management or checking them out, right? Or community supports. We gave the contacts for partnership in the chat. We'll also follow up with those additionally. And then joining the hub. You don't have to be a care coordinator to join in the system. So please reach out to Heather or Marilyn if you have any other questions about how to engage with the Pathways Hub, we want everyone to use it, right? It only works if we're all using it. So that's the message is learn how to engage with it. We have lots of resources and more to come. Next slide. Okay, this one's really exciting. Heather, do you want, Heather is thinking about the branding of this project. So if you want to talk about this, please go for it.
Sure. So in starting the creation of a lot of the documents, I noticed we didn't really have a name and we don't have a logo. So I thought this would be a good opportunity to get feedback from the stakeholders and see what everyone thinks and any new ideas. I created a PowerPoint with just some examples of sort of what I've come up with so far. And I'm not sure how we want the process to go, if we want to vote or exactly how we want it to look. So I wanted to engage everybody on it.
I can pull up the other slides if you'd like. If you want to give me
Sure.
just a second. Okay, one sec.
Yeah, and then we're going to give you guys a chance. We'll talk about it on the next slide from this slide deck, but is you'll have a chance to come up with some of your own as well. So we'll look at Heather's to get inspiration. If you want to just put in the one you like in the survey that you've already seen, or if you have a separate idea, we welcome you to fill it in. It's just a feedback survey that we'll talk about it then.
So I am so inspired by this project. I'm just so impressed at all of the work everyone's doing. And so I thought that the hub should be reflective of the county, of all of the services provided. So that was kind of the inspiration for this deck. Next slide, please. So I kind of look at this as the beginning. This is the beginning. It's very exciting. Next slide, please. I found this German proverb, and this seems to be a characteristic of everyone that helps individuals. Charity sees a need, not the cause. And I think that's the true mark of a compassionate person that's motivated to help people. It's like you don't blame the person. It's like, this person needs this, let's get it done. And I like that. I like that attitude. Next slide, please. And so to me, a name is important. It provides a glimpse of what the service is being provided. And we're kind of in a unique position. Everybody, it's a network. That's one thing I've noticed is everybody is networking. Everybody knows each other. And so really kind of bringing that all together in one place is kind of what the hub is about, so that our community members get the best possible experience. They have access to all of the services that are potentially out there. And then it's also the first impression of the clients to the hub. And so I want to convey something that conveys that everybody's caring. They want the best possible outcome for this person, that we're all trustworthy, and that we are advocating for them, we're fighting for them, and that the community also trusts us as a whole, that we do what we say what we do. And so just kind of keeping the pathways open is important, and it's kind of like the journey. That's what I look at this, like a journey to a better life kind of thing. So next slide, please. Sorry. So I was looking at logos. So the first ones I saw were the actual photos of places. I liked them very much, but then, when I tried to copy them, they didn't turn out that great, but this is also options. Next slide, please. And so I really liked a lot of these logos. The first one on the left, really, that's a pathway, and those are two homes. And I really liked that, because that seems to be what our end goal is overall. Yeah, I like the sun one too. It's like you're on the path to brighter sunny days. And so all of these pathways should lead to a stable place, to a home, and to where people will maintain their housing and have a whole entire community behind them, supporting them. Next slide, please. These were some of the other little snippets I found. I thought they were cute. I didn't think they were really probably would look that great on our letterhead, but and then so the examples 1, 2, 3, 4, and 5 are in our meeting. Everyone felt that Lake County, California should be front and center, because there's a gazillion lake counties in the country. So and some of the ideas that I had were community resources pathways hub, community connections hub, connections hub. So there's a few different ideas. So this was for me on visual, so I have to kind of see it, and then it kind of gets your juices going, makes you a little more creative. Okay, next slide, please. So I named this the Great Naming Competition. And then my information's down at the bottom. So all feedback, I'm open, my door's always open. I'm very quick to answer emails, phone calls. So this is kind of your first introduction to me as well. So that's all I have, and thank you.
I'm going to go ahead and switch back to the other slides really quick.
Julie's asking to go back to the last slide.
Oh yeah, before you switch over,
Oh.
Patty, could you just go to the last slide? Our surveys for generating new names, so I want to make sure we sit with this and have a chance for people to respond in real time. So if,
One sec, let me just try to find my way. I got so many things open.
I know it can be like your screen can get lost when you're the host on Zoom, and it can be hard to find it. Been there many times, Patty.
Oh my gosh, yeah, I've lost the.
For the green outline.
The green glow. Is there anything just in seeing Heather's beautiful presentation? Oh my gosh, Heather.
Oh
this
my
was
gosh.
awesome
Sorry.
and so next level. Anything that stands out to someone making connections? Ooh, I like that. I was also thinking of like a pathway with community at the end, because something like working in homeless services, you find that housing is not the end of the journey. Actually, it's like to maintain housing, you have to feel like you belong, and like you have your informal and formal supports that hold you as a person, right? We all need belonging in community. So maybe that with like some kind of community at the end. But I love the triangle, like it's just very attractive, and I feel like a triangle is less common in a logo. So or maybe like something that is like an octagon shape, because it just feels like there's so many connection points. So maybe a shape that indicates a lot of like different entry points. A lot of CalAIM stuff is there's a phrase called "no wrong door," and I really like that. It's like it just means try to make a way for people to come in regardless of which way they're entering from. What stands out to you guys, like logo wise, or with some of the naming examples here? Yeah, Israel, you were saying that the triangle is one of the strongest shapes, and it shows strength at the bottom. I also like that it's kind of like a Maslow's hierarchy of need is in a triangle, and we're meeting social determinants of health. So there's some nice interplay with the triangle. I think an outline of Mount Pinoctic, how do you say that? With squiggles for the water and a pathway. Ooh, that's a cool idea, Carrie. Leading the sun type imagery, like the triangle. So sun imagery, mountain imagery, the triangle is well loved. Any other feedback people have for Heather's ideas here? A giant tree.
With all the roots going kind of down. I love those trees.
Anything else standing out to people? We have a lot of feedback on circles also powerful, root to rise. Love that. Yeah, just thinking about the name. Maybe some content around the name. Does one of these stand out to you, or are you thinking maybe some other terminology that you think would be valuable? Laura, what do you think?
Yeah.
You like the triangle. I sometimes have trouble thinking like on the spot about things like this, tapping into my creative brain here. But I think keeping it shorter, like example 1, community resources pathways hub, that's a mouthful.
Yeah, it is.
You know, so the shorter and more direct we can make it is really going to serve the population well. The shorter that, if we think of our population, what their quick grab is what they're going to remember, and doing too long is going to be difficult. I do like having Lake County on it, Lake County, California, make sure we distinguish ourselves.
Yeah, Israel said that resources is kind of outdated, which I experienced the word that way as well. I have that like feeling towards it. And even though it expresses something useful, I think we could say that in a way that's like, has more pizzazz.
And then I think also thinking about what the acronym will look like, because we're also acronym driven. So.
Kim said Lake County Path to Connections. Like that. I think connections is a great word. Like it's like the great connector.
So the Lake County, California is part of the name. And I think we've sort of established that that was kind of something that would stay. And so I kind of like the Community Connections Hub because the acronym is CCN. So I can't see the other ones I have. Wait, I have 4,000 laptops here right now. Let's see.
Lake County Connections was April's input. So
Yeah.
that's very just like sweet and to the point.
LCCN.
It would just be LCC.
Okay.
Lake County Connections. Okay, y'all. This has been super fruitful. Patty, if you don't mind switching back. Sorry.
Absolutely. It's okay. I will get there.
Sorry to be with you.
That is okay.
Yeah, Heather, thanks for putting this time in. It's really fun to get to have this like community input session. And thanks for giving us the prompts that help feed our creative brains, as Laura was putting it. Great. If we could head to the next slide, and we'll be wrapping up, y'all. Paulina, I'll have you jump in here. Paulina's my colleague from Resource Development Associates.
Hi, everyone. It's so nice to be here today. I just dropped in the chat the link to our post-meeting survey. So this survey will include the naming competition, where you can add any new names or names that really stuck out to you, so we can collect them all and see if there's any repeats and see which would be the best fit. And this feedback is also great for us to hear about your experience during our presentation and during this meeting. We want to know what worked, what didn't work. We want your feedback. So if you have 3 minutes, it would be amazing and we would greatly appreciate it. And then now I'm going to hand it back over to Scott to close us out. So thank you so much.
Thanks. I hope everyone got something out of this. We live in exciting times. And this is three big forces that are coming together. We have the Pathways Hub, we have Coordinated Entry, and we have CalAIM. And they're all kind of converging at the same time, which is really interesting. And I believe strongly that this convergence will have a great positive impact in our community. I think we've all been to plenty of meetings in the past where it's been lamented that we're feeling siloed, that we're not working as well together as we should. And these three entities coming together, I think can really change that. We're a community with limited resources, and so we need to be able to work together. This provides us that ability to work together. And so I think we're headed really in the right direction. I strongly appreciate you all being here. Community input is vital for these projects to take place. This is a really big one because it's going to affect our entire community. So having your input is extremely important, and having your participation is also extremely important. We're all here working for the betterment of our community and to help those who are the most vulnerable. And this is a process to be able to do that. So thank you for your dedication to that cause and for being here. Thanks.
Thanks, everyone. Have a great day.
Thank you.